Thank you very much for joining us today. On behalf of US Cardiology Review, I'm Dr. Alex Truesdell, and today I have the great pleasure of welcoming Dr. Rani Upadhyay from Stanford Health System in Northern California, and Dr. Mir B Basir from Henry Ford Health System in Detroit, Michigan. And today they're going to talk to us a little about their a manuscript that they've just put out discussing the current landscape of temporary mechanical circulatory support devices. So I'll just kind of turn it over to you, Dr. Upadhyay, to give us an overview of the manuscript and some key points that you'd like to express to the readers/viewers.
Okay, thank you so much. Thank you for having us and giving us the opportunity to write this paper. It's been a really great experience. The main goal of the paper was really just to go over the current devices that are available to us in the treatment of mechanical circulatory support. So we wanted to kind of go through each of the devices that are available, briefly go through the way the access points of the devices, the hemodynamic benefit of each of the devices, and also potential complications of the devices as well. And then we break down the paper looking at mechanical circulatory support in patients presenting with acute myocardial infarction, and then also looking at patients with a non-ischemic cardiomyopathy, just looking at the current data available, supporting or not supporting current use of devices, and also giving different key points in terms of what can be used depending on the availability of the clinician and also of the hospital in terms of what device can be used and how it may benefit the patient.
Great, that's fantastic. Yeah, I've sort of, when I think back, we're sort of spoiled with an abundance of riches in terms of mechanical circulatory support devices. And in some ways, it was easier when you had cardiopulmonary bypass and intra-aortic balloon pump. And I think it's a yin and yang. So it's good. On the other hand, we've had some of our talks already about the importance of hemodynamic monitoring, about staging of cardiogenic shock, and about tailoring these therapies to patients, which brings in a whole lot of complexities that I know the two of you have been at the forefront of investigating that. And maybe Dr. Basir, you could sort of touch a little bit upon those issues.
Yeah, I think those are paramount. When we're talking about choosing between the devices, I think it really boils down to the principles that you mentioned. Firstly, the way that we broke it down in the paper was really based on shock phenotype. So we know that there's two major phenotypes in cardiogenic shock: the acute patient, particularly the acute AMI patient, whose brain, kidneys, liver, they're used to seeing 5 liters, 6 liters of cardiac output on a regular basis. And when they come in a compromised state, they need a little bit extra support to be able to help get them through the early phase. And then this larger group of decompensated heart failure cardiogenic shock, the advantage of the latter group being that they actually have some physiologic compensatory mechanisms already in place, so that they may not need as much support early on, but not a lot of reserve. And so when they do need support, when they've gone on to stage D and E shock in particular, where they need really complete taking over of the heart so that they can be bridged to LVAD and transplant. And then, just as you mentioned, we've done a lot of work with the SCAI shock classification system to really be able to be granular about talking the same language, so that when I'm asking Rani for advice on a patient in California and I say stage D shock, well, she knows the same stage D shock that I'm talking about. And that, I think, opens the line of communication quite a lot amongst ourselves. And then really spending time, not just taking the measurements, but really spending time understanding the measurements that we take with invasive hemodynamics, and taking the whole clinical picture into context, imaging, so that we can do what's best for the patient and provide them ideally with the right support the first time to get them out of shock, and ideally avoid the need for escalation if it were to occur.
Now, those are fantastic points. I think, what I'm hearing, and same thing I sort of practice, is thinking about, that phenotype, as you mentioned, acute MI versus acute decompensated heart failure, or, I like the term that I've heard, chronic anaerobe. So they live at a different steady state, which you sort of alluded to. The different, so that phenotype, the stage where they're presenting in that SCAI shock stage, what other organs may be involved. And I think, Dr. Upadhyay, you also mentioned, the expertise of the team, both with different devices and with different types of patients. And then something else provocative, I think you mentioned, Dr. Basir, was this idea of getting it right, the first time. And certainly there's a big debate about whether you go, very aggressively upfront with the most supportive devices, or whether you escalate slowly. I think that very, very controversial topic. I'm not sure that we have the answers, and there's a lot of ongoing investigations, but I want to kind of get your personal thoughts in that regard, Dr. Upadhyay.
I think, one of the key components that both of you had mentioned is, the main thing is early recognition of cardiogenic shock. And that starts, I think, in the intensive care unit and in the emergency department, to recognizing that this patient is in shock and getting cardiology involved. And then, like both of you mentioned, trying to figure out what the best device is. I think in terms of, the going big, that really depends on the clinician's expertise. I think a lot of the times, people may shy away from going in with tandem heart or ECMO just because they haven't placed it, or they may not have the, CT surgical support to do those devices. So they tend to start with an intra-aortic balloon pump, which, sometimes isn't the wrong thing. But I think, like how Babar mentioned, recognizing and interpreting the hemodynamics and knowing that, this is not going to be enough support for this patient because they're requiring 1 to, inotropes, have been on it for hours and are still not improving, really is the key point, is recognizing that they need more support, whether that be maybe they need to get another interventional cardiologist with more expertise involved, or transfer to a higher center for that escalation of care. So I think the limitation in terms of going big versus starting small sometimes depends on the expertise as well. And like you mentioned, I don't know if we have enough information about what will be beneficial. Because right now, a lot of the patients that we're seeing being placed on, for example, ECMO, are the sickest of the sick. So we're seeing that they're not doing well. But I think it would be interesting to see studies in which somebody who is on, 1 or 2 inotropes, not progressing, is placed on VA ECMO right away and seeing what their outcome is, versus waiting until they're already, not doing well on an Impella and then placing them on VA ECMO, which we know the outcomes with those, patients are not as good.
No, those are great points. And Dr. Basir, I was going to ask you to comment further, and also maybe take it to the next step, where you think maybe is an unmet need in temporary mechanical circulatory support, and in your dream world, what we would do now and where we would, go to in the future.
Yeah, I think, MCS is still a double-edged sword. So we see the hemodynamics, and I think we focus in on talking about that now. And amongst ourselves, we spend a lot of time at meetings discussing how we're going to, which support we would use in which patient. But the key component of this is doing it safely, right? And so, there are inherent complications that come with hemodynamic support devices, and then each different hemodynamic support devices carries its own set of complications. And so I think that that's something that we all really need to appreciate during these discussions. The good news with all of this is the future is really bright, as you guys both know. I mean, this is an area where there's a lot of technological advancements. We are going to continue to see the development of smaller devices and more powerful devices. I think our understanding of both the clinical need, the the importance of invasive hemodynamics, the bridging to more durable therapies like LVAD and transplant will really be a key mechanism for the continued growth of MCS. And so what I always tell our fellows and trainees and early career physicians is spend time learning, spend time with people who know and have experience with these devices so that you can gain that experience. And for those who are even a little bit more junior, pick hospital systems to train in that use these devices so that you have a good fundamental training of all of the technologies that are available so that you can offer your patients everything that they potentially could need.
Now, those are great points. And one thing, and I don't know what the experiences of both of you are, but I sort of think back to my training, and I didn't train that long ago. And I think, where were all the cardiogenic shock patients? And I wonder, were they all on the cardiac surgery service? Were they all, they weren't at the forefront. Now, one, I understand that the population has been getting sicker. We've been getting better at identifying patients, recognizing them early. But also, I think this overlap between cardiology, cardiac surgery, critical care, advanced heart failure, and, with everybody being involved much more collaboratively, particularly as the patients get more complex and as the therapies, especially device-based therapies and multiple pharmacologic therapies, and with all of these working sort of in concert, that this team-based care becomes really, really paramount. But it's an interesting observation how I think both the patients have changed and our approach has changed, and I think we've been getting better in being more collaborative. And I'm just curious, in our last few minutes, some of your thoughts on your experience both at Stanford and then at Henry Ford System, about how that works with managing these devices in collaboration with all the other specialties. So I'll start with you, Dr. Upadhyay.
I agree. It is a big collaborative effort between all, a lot of different departments. Generally for us, it is the hospital system that I'm at right now. We don't have our particular advanced heart failure doctor. So it is between the intensive care doctor and then us interventional or general cardiologists that are managing the patients. And then also the devices, in collaboration with nursing staff and all of that.
Yeah, and as Alex, as you know, we're in a different boat than what Rani is in that we have, we're the advanced transplant, advanced hemodynamic support and transplant center for Metro Detroit. And so it becomes really easy because we have everything at our fingertips. So we have 10 interventional cardiologists, all of who do shock, all of who do alternative access, 6 to 7 advanced heart failure docs who consistently do this on an everyday basis, and then 4 transplant surgeons. And so, this core group of people, kind of fundamentally helps take care of these patients on a day in and day out basis. But we can't even begin to thank you and the Inova group for all that you've done for this whole field in really establishing not just the importance of the cardiogenic shock team, but also really giving people fundamental steps to be able to help each of their individual hospitals mimic what you all have done, because there are very few centers that have all of the capabilities like I was privileged to work in, but extremely a large number of hospitals who have parts of that. And how do you take the parts that you have to be able to still deliver extremely high quality care? Because the vast majority of patients, as all of us know very well, continue to come to smaller hospitals where they that are cath lab capable centers that may not even have all of the regular MCS devices that are currently available.
No, that's a great point, and this sort of brings everything full circle. And as both of you may know, so I'm in a large private practice cardiovascular group, and we cover, we have 11 offices, 7 hospitals, and 5 cath labs across 3 different health systems. So I could be Monday night in a cath lab that's balloon pump capable, primary PCI capable only, and I could be Tuesday in a VAD transplant center. And so you want to, the goal is to have the same standard of care and the same availability of the care and the same equitable care to everybody within the community. And that really requires a lot of collaboration between centers, between physicians that may, quote, compete in other arenas, but really have to collaborate in the space of these sickest patients. And I think particularly in the US, that's a major challenge for us to work through to improve the care for everyone. And I think about some of the efforts that a lot of our colleagues down in Georgia and Jeff Marshall and some other folks in particular that looking at legislative efforts to establish level 1, level 2, level 3 emergency cardiac care centers to route patients appropriately and to codify the collaborations between centers. So it kind of goes back to also when you talked about what devices might be the best devices or what might be the right best first devices depending on where you are, but incumbent upon people to then communicate further with their other colleagues and using that common language that you talked about from the SCAI shock classification system to use those that hemodynamic data so that we're all collecting and discussing the same data and to talk about those different phenotypes so that we can really communicate better and better tease out patients that perhaps are best kept in a level 3 institution, ones that need to be transferred to level 2 or level 1. So I think, great points all around. It's a fantastic manuscript, really covers a lot of the up-to-date data and information regarding the whole spectrum of temporary mechanical circulatory support devices available to the modern interventional cardiologist, advanced heart failure specialist, cardiac surgeon, and critical care intensivist. So thank you very much for your contribution. Thanks for taking time out of your day for joining me. And thank you to US Cardiology Review for hosting this video interview and also for hosting your fantastic manuscript. Thank you.
Thank you.
Thank you.